my talk today is about learning curves and new technology and the adoption of all these things that are happening. And I thought it'd be a good talk to kind of get some ideas. My first question is, of all the surgeons here, anyone using robots right now? Okay, great. So half the room maybe. You're going to eventually have something come into your OR that you want to use, whether it's endoscopy, whether it's robots, whether it's this or that. And so I was trying to figure out how best to kind of put this all together. And maybe one of the questions today was on going back and adopting technology into the room, into your own room, and should you or shouldn't you? Should you leave it to the experts to start first and publish? So a lot of good relevance to what I want to talk about. Navigation, and the reason I want to talk about it, because navigation we've been using for a long time. Since 2007, we basically apply it in every aspect of surgical, of spine surgery. Recently, in December of last year, 2019, so only about a month ago, we acquired our first robot. And it gave me a sense of, well, how do I bring this into my OR safely? Because when we first used navigation as our initial experience, there was no training program. It was winging it with Pat Johnson kind of thing. And Pat's like, I had a generation of navigation experience, I can figure it out. It's an O-arm, it's probably an imaging modality, just like a fluoro. How hard could it be, right? And unfortunately, we learned after a couple thousand cases that it is hard. But we've done a lot of things great with navigation. It's an enabling technology. It allows a surgeon, it enables a surgeon to do things that they currently weren't able to do before it. And so it's something where you can't ignore it, you can't resist it. You have to bring technology in order to make you a better surgeon. And these are some of the cases that Pat and I shared: complex Klippel files, screws that are going in places with revision, laminectomies and settling, chin-on-chest deformity after a wonderful previous fusion, being able to instrument that with cervical pedicle screws to get the head back into proper position, big deformity cases where all the pedicles are atretic, and you end up instrumenting multiple levels, durable constructs that last for years. And this enabling technology is allowing us to even further refine things like MIS T-lifts, as well as MIS Scoles, as well as spinal oncology. This is I believe it was a renal cell resection, partial sacrectomy and reconstruction with 6 pelvic screws. And so what did we learn with navigation? It enabled us to do those great things. What we understood is that workflow, which is the new vocabulary with new technology, is extremely important. Surgeons need to think it out before they wing it. They need to think through each of the steps, and this is not something you learned in residency, and it's not something that was taught to you in your classes, and this is something that every surgeon needs to do whenever they're adopting new technology. It will guarantee efficiency, it will guarantee time and cost savings, and it allows you to start standardizing your procedures. It gives you an ability to refine and become more efficient if you're starting to have a standardized workflow. Also, with new technologies, it'll help adopt it. So here was our kind of initial thought with navigation. Fluoroscopy was a 3-person thing. It was primarily the surgeon that was driving the fluoroscopy. In spinal navigation, we realized it's a multi-team approach. There are a lot of people that are involved in order to make it work. And if you don't pay attention to this, you get poor workflow. And what we studied at Cedars was this concept called flow disruption, right? Longer OR times, longer acquisition times, more steps in the procedure, and any step along the way, if you're not paying attention, if you haven't thought it out, you're going to have a problem where it gets impacted negatively. And so you hear people saying, I don't use navigation because it slows me down, or I don't want to use robots because it slows me down. Just had a dinner conversation about that. And unfortunately, these things happen at the cost of our patients. So this is real stuff that you need to be thinking about, because you don't want to be that surgeon that says, no, thank you, I'm not going to use this technology ever again. Don't be a honey boo-boo. We are frontier people. What we also learned from navigation through all the literature is it's not this. It's not the more you do, the better you get. Okay, this is a traditional surgical learning curve that I pulled from the general surgery literature. It's different. Your accuracy with navigation is pretty consistent. You're pretty excited that from case 1 to case 16, you're nailing those pedicle screws perfectly, which is, historically a difficult problem. But other things do improve over time as you get better and better. Your OR time shortens, radiation exposure shortens, and what we learn is, and what we're about to publish is this learning curve for navigation. And so when you first start, if you look at this curve, when you first start, you're super accurate, you're super excited with your 3, 2, 1 level fusions, and you think you're doing great. But then around the 50 case point, you start realizing as you apply it to harder cases that there's a lot of issues going on. And people, coordination, bringing the O-arm in, having everyone proficient at what they do. And if you're not thinking about these things, if you're not mastering the environment around you, you're going to have a problem. You're going to have a situation where you do put a screw in the wrong place, and then you'll discard it because you won't be thinking, you'll be blaming the technology, but you won't be blaming yourself. And so you have to understand workflow. And if you master this workflow eventually, you start becoming more proficient. That's the later part of this learning curve, where at the final point, you become even more proficient than when you started. So bring on the robots. What are we seeing with this? The reason why I'm here today is I wanted to talk about our early experience because I didn't get to do it really with navigation at the time we were going through it. There's a little tailwind here where we have studies, very good studies by Mike Wang even from yesterday about robotic early learning curves. And what we realize is the robot is a little different. The learning curve is less of a workflow issue, more linear in nature. And so if you look at that left-sided or your right-sided curve, the number of cases you do, the total time per screw, it remains constant. If you're a PGY1 or a PGY8, pretty constant. And whether you've done 1 case or 7 or 10 cases, it seems like pedicle screw insertion times, OR times, it seems to be pretty consistent. And what we're learning is that it's a different process, which is probably a good thing. And so as we try to analyze this technology, you're thinking a learning curve where the more you do it, the better you're going to get. And that's been our initial experience. We did do something different, which is when one of the questions were asked about how to adopt it or how to bring it back to your own place responsibly, this is what we did. So we're big navigation guys. We said we don't need anyone training us for robots, but I decided to partner with the robotic companies to do a little training protocol. Not a cadaver lab weeks before, but an actual formal proctorship program. And so this is what I did. I looked at the software, I played with it in the afternoon, I assembled our best team, OR team at Cedars, our best scrub techs, our best nurses, people who were excited about the technology, because this is what you need to do if you're going to succeed in the OR. We did a full dry run 3 days before my cases. Everyone was there, the OR staff, the reps, everyone. We worked through, we had a true trainer, we actually used the robot in its process from beginning to end. We looked through every aspect of that workflow to understand where the trials could happen. We worked on disaster bailout programs or plans in case the robot failed or something happened. And then we went to UCSD. We worked on another dry run on real cadavers. We learned about the concepts of skiving, the tolerance, where to put our pins, and so we worked all this out. This is how you responsibly do it. And then finally, I reached out to one of the experts in Tucson, Richard Chua, went over my workflow with him, asked him questions, worked on details. One day before, we did our first robotic case at Cedars. It went perfect. So 15 plus cases later, there are many speakers out there that have 100 plus cases, so they'll probably chime in as well. There is value about thinking about workflow and pre-planning and team mentality. The learning curve is not as steep. With robotics is what we're learning. With appropriate training, without appropriate training, you're going to expose yourself to frustration and ultimately patient safety. And doing this kind of training program, be humble. Don't think that you don't need it or you don't have time. You have to invest in it if you're going to adopt new technology, because the goal is to accelerate through that learning curve to point B as fast as you can, not at the cost of your patient. Adopting new technology in general, what spinal navigation taught us was workflow, multi-systems, multi-team. It emphasized the proficiency of all team members. Flow disruptions are everywhere. In spinal navigation, we're studying it in robotics, it will likely be. Every new technology you adopt will have a different learning curve. Scan the literature, understand what the issues are and where it's becoming a problem, because you need to understand this adoption in order to successfully do it with the ultimate goal of patient safety. Thank you very much.